reflux, abdominal pain, and constipation. So these are the things that you really need to have really a very clear, measured approach to and understand these problems and be able to deal with them in a sensitive and realistic way.
I think a fun thing is how commonly these things interact and are present in the same patient.
Absolutely. You know, we talk about constipation, we talk about overflow diarrhea. Clearly Dr. Wallach is right on with that. So what are our learning objectives? You want to learn the varied presentations of functional constipation, understand the approach to diagnosis and management, know the warning signs which may indicate a serious disorder, apply pharmacologic and behavioral educational interventions to treat this disorder, and to recognize the presentation, diagnostic approach, and management of Hirschsprung disease. And most importantly, while you may think deep in your heart that constipation is a trivial problem, I can assure you the parents of these children do not share your opinion. And so to them, this is a very, very, very serious problem. And so the education has to take place not only for the child, but importantly for the parents to understand why this happens and what we can do about it. And what I've always frequently told parents is, you know, the problem didn't develop in a week. It's not going to go away in a week. So we have to work on understanding it and managing it appropriately. Okay. Dr. Khan, you want to read this one?
Sure. A 6-year-old boy presents because of diarrhea. The child was toilet trained at age 3 years, but he has been soiling his underwear for the past year. During meals, he frequently complains of abdominal pain, and his soiling episodes usually occur in the afternoon. He's experienced no fevers, other illness, or weight loss, although his parents are concerned about his decreased appetite. Physical examination demonstrates a well-developed child whose height is 43 centimeters at the 50th percentile and weight is 19 kg at the 25th percentile. He has normal bowel sounds, and a movable, non-tender mass is palpated in the left lower quadrant. Rectal exam is deferred because of a large amount of semi-liquid stool in the child's underwear. Of the following, the most likely cause of this child's symptom is A. Celiac disease, B. Fecal overflow incontinence, C. Giardiasis, D. Hirschsprung disease, and E. Irritable bowel syndrome. So I'm going to go with B. Fecal overflow incontinence.
Well, you will be right. I would normally quickly say, write your answer down. We'll give it at the end of the session. But obviously, this is the case here. But there will be other cases that I'm going to present at the close of the lecture. But you're correct. This is a typical fecal overflow incontinence. So let's talk about the scope of the problem. The peak incidence of constipation is at the time of toilet training, not surprisingly. 5 to 10% of school-aged children have some sort of a defecation problem. It's estimated to account for 3% of general pediatrics office visits. I'm sure Dr. Levine, Dr. Wallach, and Dr. Rabinowitz will tell you that it's more than 3% of pediatric gastroenterology visits. Treatment success by pediatricians is only 34%. And that speaks to the time that the general pediatrician has to deal with the problem, but also the approach in terms of medical therapy. And again, as I mentioned earlier, I'm sure it's greater in pediatric GI, so it accounts for estimated 25% of pediatric GI visits. And as I said also, parents are extremely troubled by this. They're afraid that something is wrong and that this is a dangerous problem. The disorders of defecation can be broadly divided into 4 distinct groups: infant dyschezia, functional constipation, functional fecal retention, and functional non-retentive fecal soiling. And we'll go over all of these, but they are all different, and they all speak to really different idiopathogeneses. Infant dyschezia is characterized by at least 10 minutes of straining and crying before successful passage of a soft stool. What I always tell parents is one of these days, you try to have a bowel movement lying on your back. It's very difficult to do that. Not only that, but when we sit on the toilet, we straighten our anal canal, which is normally at a relatively acute angle. And by straightening the canal, we make the passage of stool easier. An infant can't do that. So infant dyschezia is really a very, very common problem. There is really no specific treatment for it other than reassurance, and it is a problem which will eventually resolve. The infants are otherwise healthy, typically less than 6 months of age. And again, no workup is required, explanation and reassurance. Functional constipation is common in infants and in toddlers, characterized by pebble-like hard stools, where the passage of a firm stool occurs 2 or less times per week. There's no evidence of structural, endocrine, or metabolic disease. The etiopathogenesis may be one of hydration, maybe one of diet, or maybe one of a developing motility issue, which again will eventually resolve. Functional fecal retention is what we call the classic stool withholder. This is the toddler who hides behind a curtain, who runs away, who's doing what we call the duty dance up on their tiptoes. Functional fecal retention can also occur up to the teenage years. And you see in the second line the prevalence. It's much more common in boys than in girls. Generally, it includes the passage of large diameter stools, less than 2 a week, and they have a retentive posturing, which is stool withholding. They contract their pelvic floor muscles, stand upright, walk on tiptoes, turn red, buttocks get squeezed together, rocking, dancing, hiding. I have this classical case of a patient referred to me years ago, had been seen at the Neurological Institute at Columbia for a peripheral neuropathy, presented with legs stiffening and shaking for no reason, had a major neurological workup. Well, didn't take too long to figure out that this young boy, who was about 9 years old, was just constipated and was a fecal withholder. And as soon as we relieved his fecal impaction, his stiffening and shaking stopped. So in these patients, they'll typically have a dilated rectum. Certainly, if you're not going to do a rectal exam, which can be deferred, a plain film will show a dilated rectum. They commonly have fecal soiling and overflow incontinence, just like the patient that Dr. Kahn read in the beginning of the lecture. Non-retentive fecal soiling is typically in a child greater than 4 years. It accounts to up to a third of all children with soiling, and this happens once a week for at least 12 weeks, defecation in inappropriate places and at inappropriate times. You know why? Because these are children who typically start out as stool withholders. And typically this happens either at school or on the way home from school, that they just can't hold it anymore, and so they defecate in their underwear. These patients have no structural or inflammatory disease. There's no signs of fecal retention. And these are patients where behavioral modification does have a significant role in alleviating the problem. So we've talked about all of these constipation states which are not involved with any structural or metabolic abnormality. That is not to say that constipation can't be associated with any one of a number of pathophysiological states: anatomic, metabolic, endocrine, neuroenteric, systemic, drug effects, primary GI disease, including celiac disease. Patients with celiac can present with constipation, as can patients with cosmoprotein intolerance. In the latter case, they're often stool withholders because of pain. In the former case, because of fat malabsorption and the presence of a very bulky stool. And of course, there are other situations as well. Again, one thing we don't may have a discomfort talking about, but the child who's been physically or sexually abused commonly presents later in life with issues of constipation. And this is something that you certainly don't think about with every patient, but something you really do have to keep in the back of your mind. So again, we're dealing with a legion of disease states, all of which can be associated with some element of a defecatory disorder. The first thing we need to do, obviously, is a thorough history and physical examination. When did this start? When did the baby, as it would get an infant history, when was the first bowel movement? Keeping in mind that patients with Hirschsprung disease are often not diagnosed specifically until after the first decade of life. And we'll talk about that later on in this lecture if we have time, or if not, the next time. What are the frequency of bowel movements and their characteristics? Does the patient have accidents, this non-retentive fecal soiling? Are there associated symptoms? Has there been any treatment? What's the diet like? When and how was the child toilet trained? Is there a family history? And has the child had a previous evaluation? These bullet points should be covered in every patient you see presenting with constipation. And then in terms of physical examination, is growth normal? What about thyroid function or any indicator of thyroid dysfunction? Are there the presence of abdominal masses or abdominal distension? Rectal exams are not required in all patients with constipation. If it's a typical case of functional constipation, in fact, I recommend not doing a rectal exam. What I like to say is the child doesn't want anything coming out of their rectum. They certainly don't want anything going in. So again, there is a place for rectal examination, particularly when you suspect something like Hirschsprung's or an inflammatory disorder or some other metabolic or physical problem. But in the typical case of functional constipation, it's not required. That does not mean you shouldn't have a visual inspection looking for cracks or fissures. Again, a little clinical pearl. In patients with constipation who present with an anal fissure, that anal fissure with the patient in the supine position will always be in the 12 or 6 o'clock position. When the fissure is somewhere other than the 12 or 6 o'clock position, in the supine position, that suggests some other physiological or anatomical problem. The spine should be examined for evidence of spinal dysrhythism. Is there a tuft of hair? Is there a dimple? And then obviously a neurologic examination peripherally should be conducted.
Dr. Schwartz, I always also ask for Miriam about presence of blood in the stools when as part of the associated symptoms.
Yeah, generally though, when patients, that's going to be the red flag. When family sees blood, they're going to come. Usually the patient with constipation who has blood in the stool, it's either going to be blood on the toilet paper or blood on the outside of a hard stool. And that's very typical for constipation-related hematochezia. What are the red flags? What are the things that really alert you to a more serious state? Failure to thrive, weight loss, delayed passage of meconium, abdominal distension, the presence of lumbosacral anomalies, an anterior displaced anus. Remember, we talked about having to straighten the anal canal. The more anteriorly the anus is displaced, the more difficult it is to do that. Again, is there occult blood in the stool? Obviously, if there's any suggestion, one should get a hemoccult test. And are there any neurologic findings? Any of these alert you to the possibility of a more significant problem other than a functional disorder. There are many potential diagnostic tests that can be conducted. Abdominal films, lab screening, other imaging studies, anal manometry, biopsy, something called the Sitzmark test, which you can look up, which measures colonic transit using radio opaque markers, MRI of the spine, and finally colonic manometry, which is really more of a research tool than anything else. A spinal MRI is indicated if there's constipation with a neurogenic bladder, if there are any neurologic signs in the lower limbs, if there's an absent anal wink or abnormal sphincter tone. In 75% of these cases where there is a spinal abnormality, it will be a tethered cord. And of course, this should always be preceded by a sacral X-ray to see if there's any evidence of spinal dysrhythism. So again, depending upon your examination, that will determine whether further diagnostic imaging studies are required, certainly in this case. So, once we have ruled out any significant disease state, because we're not going to talk about the management of constipation in all of these other disease states, how do we manage functional constipation? Well, fiber, fluids, and osmotic sugars have long been the typical way of managing these patients. Of course, we'll talk about PEG 3350 as we go on. Lifestyle modifications, exercise. It's amazing to me how many of these kids who come in with functional constipation are couch potatoes. They get very little exercise. They generally sit and eat in front of the TV or the video, or they're locked on to some LED screen. So once we can manage diet, lifestyle, and then the issue of behavior modification can be very helpful, particularly in the child who's in the last half of the first decade of life, where we give them calendars and gold stars. And if they get so many gold stars in a week, they get a prize along with regular toilet sittings. I think all of us attendings have our own methodology for doing this, and it's not always going to be the same, but it's really it's a tried and true mechanism. I find in the 8 or 9-year-old child with functional constipation, sometimes all we need to do is behavior modification, which is enough to get them to make more regular use of the toilet. And then finally, medications can be attempted. Not even finally, it may be one of the initial stages of therapy. So behavioral therapy, we term enhanced toilet training. So a 4-year-old sits on the toilet. Where is the 4-year-old's legs? They're dangling from the toilet. The only way that one can exert the proper downward pressure is to put your feet flat on the floor, if not on the floor, on a step stool, or a series of well, we don't have phone books anymore, we can't use those, but typically a step stool. So appropriate positioning, appropriate straining, regularly timed and uninterrupted toileting. Child can't get up at 7:30 in the morning and have to be out of the house to school at 7:45. We get to get the child up earlier, allow them to have breakfast at home whenever possible, and then give them time to use the toilet. And then a symptom and toileting diary. Again, this can be used as a mechanism of behavior modification. Whatever the case, define specific achievable target behaviors and emphasize consistency. Great problems, especially when you have a separated family where the child spends some time with the mother, some time with the father, and they don't manage the problem together and consistently. And so when I tell parents, if your child has 3 or more bowel movements in a week without complaints or without symptoms, they get a reward. The reward, I say, maybe bigger than a lollipop and smaller than a bicycle. It should be something that the child is motivated for, but obviously you don't want it to be excessive. And the most important thing, as I mentioned, is consistency in approach. Very often we get a child who comes in with a fecal mass that is so large that it's difficult to pass, and so we have to engage in disimpaction. And disimpaction can be handled in a number of ways. Prior to the advent of Miralax, we typically used enemas that were either mineral oil, phosphate soda, or saline, and we really don't use those anymore to any great extent. I try not to use enemas whenever possible. Again, this has been made possible by the advent of Miralax, and I try not to use enemas for the same reason that I don't do rectal exams on every patient, because the child really fears anything that crosses the anal barrier. Suppositories can be very helpful initially, including Dulcolax or glycerin suppositories, and then in the most refractory cases, manual disimpaction in the OR under general anesthesia may be required. So, are the other drugs used for disimpaction? Obviously now, when we admit these patients to the hospital, or if they're compliant and will drink the stuff at home, we try an oral lavage with polyethylene glycol. Again, when we do the infusion of polyethylene glycol, it's 25 milliliters per kilogram per hour, given by nasogastric tube. Some patients will drink it, and if they'll drink it, that's cool, that's fine. And then the dose of PEG 3350 is 1 to 1.5 grams per kilogram per day. The major problem with the management of constipation, certainly by general pediatricians, is underdosing. I always told parents, I'm giving you a lot. Your child may have a large bowel movement and may develop diarrhea. If so, let me know and we'll cut back on the dose. But to start low and to keep it raising the dose and raising the dose and raising the dose doesn't make a lot of sense. I like to give a large dose on a daily or twice daily basis and then cut back when necessary. Other stimulants, I know Dr. Rabinowitz has good experience with Senna. I typically don't use it, but again, it is one of personal preference. And then I try to stay away from Dulcolax, except as a bowel cleanout regimen. I may initially, in fact, in an older child with constipation, actually put them on a bowel cleanout regimen similar to what you would recommend prior to a colonoscopy to get them cleared out immediately. That would include Dulcolax and Miralax, or Dulcolax and phosphate soda. So that's a good thing to do, especially for a child in the second decade of life. Other osmotic agents can include magnesium citrate, mineral oil. We don't use it anymore. As you know, it certainly is verboten in very young children because of the risk of lipoid pneumonia. But all of these agents have pretty much been supplanted by PEG 3350. In the maintenance phase, again, there's the PEG 3350 up to 1 gram per kilogram per day with a very wide range. All right. This range, 1/4 to 1.5 grams per kilo per day, yielded a mean of, in one study, this is Warren Bishop out in Iowa, of 2.5 stools per day. Obviously, that's more than we would typically like. I generally aim for 3 or more bowel movements per week that are not hard, not painful, not associated with straining, and not associated with withholding. Okay, let's go to the next problem, that of functional non-retentive fecal soiling. This is up to 1/3 of the patients with encopresis. They have no difficulty with the defecation, normal frequency. They have a higher frequency of day and nighttime enuresis than do children with functional constipation. Again, as I mentioned, it's more common in males. They have a greater incidence of associated psychologic problems. You don't see any examine any retained fecal mass, no rectal dilatation. And again, sometimes we use bulking agents. I've never used loperamide, although there is literature about this. But typically, toilet training with a reward system is the most effective in this group of patients. So, why all this talk about polyethylene glycol? It's a non-absorbable, tasteless, inert osmotic agent. It's non-toxic. Its LD50 in rats is greater than 50 grams per kilogram. It's palatable. It dissolves in everything. But I tell parents, dissolve it only in clear liquid so you can see that it's all dissolved. It's effective for fecal disimpaction, chronic constipation, and encopresis, and long-term use appears very safe. My favorite way of mixing it is I tell parents to get the pint bottles of Gatorade and to, without the child looking, to put it in the Gatorade, shake it up, put it in the refrigerator, and give the child Gatorade not knowing that there's PEG in it. Sometimes if a child knows you're giving them medication, they'll refuse to take it. It's a good way of hiding it. But you'll all come up with your own techniques of doing this. I can't remember the last time I had difficulty giving this to a child. It is odorless and tasteless and does dissolve in all clear liquids.
There are like some parents who claim that their children can taste it, and Dr. Wallach at one point pointed out that it can kind of disrupt the surface tension of the liquid, so adding it to something with flavor can be more helpful.
Yes. I don't do it with water. That's why I choose Gatorade usually.
The other thing that you'll come across in some communities is that there's this like internet conspiracy theory saying that Miralax can cause neurologic symptoms in children with autism. That one can be particularly challenging.
Yeah. Well,
autism causes Miralax, not the other way around.
Correct. And
well, again, this is as much, and I think Dr. Levine really emphasized the point that this is as much about treating the parents as it is about treating the children. And so if you can conquer the parental concerns, then that'll go a long way to conquering the problem in the child.
yeah, and one of the things that I tell families a lot is that one of the hardest things about treating constipation is not the medications and the medical aspect, but it's actually the behavioral component. And I'm sure you'll get into that, so I'll save some of my comments for later.
So again, we talk about the fecal non-retentive soiling. There is a very significant incidence of associated behavioral problems. So constipation, as an isolated problem, while it occurs, one has to be mindful of the fact that there are not only other medical problems to confront, but mental health issues that have to be confronted as well. What about the long-term use of polyethylene glycol? Studies have shown in long-term follow-up no problem with non-compliance, no clinically significant side effects, no tachyphylaxis. One report of a transient elevation of AST, which resolved while still on therapy, normal electrolytes and renal function. And I tell parents, be prepared for months of therapy. This is not something it's not a one-shot deal. This is something that requires time. But again, as Dr. Levine mentioned, some parents will be very reluctant, and it can be a difficult problem to manage. Age-appropriate discussions, drawings, use of play to explain the problem and treatment plan to the child. Reassure that, one thinks about some things as a laxative. When I think of laxatives, I think of stimulants, something that stimulates motility, or it's an irritant. All we're dealing with here is an osmotic agent. Nothing more, nothing less. One is not going to become dependent on an osmotic agent. Alleviate, someone wants, who's to blame for this? No one's to blame for this. This is the end result of a number of problems that are internal to the child and external to the child. And, again, this is going to sound really sort of sugar-coated, but I say the only thing you can blame yourself for is not loving your child. And other than that, let's come to the root of the problem, let's discuss it, and reach a conclusion. Behavior modification and positive reinforcement cannot be emphasized too much. The use of the calendar, gold stars, the use of the reward system, not for every bowel movement, but for a successful week, can be extremely helpful. And indeed, as I mentioned earlier, in some cases can be the only therapy that's needed in order to effect a positive change. The goal is to improve compliance. The goal is not to cure the problem in a week. We're looking for steady improvement over time. There are various modalities to try and taper whatever medication you're on. Here it says tried every 3 to 6 months. I use a different yardstick. I say if the child is on Miralax and is having at least 3 bowel movements a week without problems for a month, we can try lowering the dose by 1/2. Do that for a month. And if after 2 months, the child on half that dose of Miralax is still doing well, we can try them off the Miralax. At any time that they fall back, you go back to the original dose. Stopping medications too soon or underdosing is the most common cause of relapse. So the parent will say, oh, gave them Miralax, day later had a big bowel movement, now I'm going to stop it. Not going to work, problem's going to resurface. The response at 1 year in terms of the natural history of constipation is up to 60%. Some of the older studies said that, looking at some years later, 80% of patients had responded. The success rate is higher in those without encopresis. The success rate is higher in those who were older than 4 years of age at diagnosis. That's because of the use of behavior modification, which really can't be done at less than 4 years of age because of the child's age and mental abilities. Half the patients experience at least one relapse. If you have a child who's older than 16 with this problem, there's a greater likelihood of the problem persisting. And the literature says that about 1 in 5 patients with constipations will have either intractable or recurrent symptoms. Again, these are just studies based on prior reports. They don't suggest that that's going to happen in your practice. When you have children with intractable constipation, particularly the older children, Annie, are you using any of these drugs anymore?
I don't, but Tom might.
I've used linaclotide, which the patient has to sign a release for, and it's worked. I've not used.
I very rarely use them. They're all sitting at about an NNT for just basic efficacy of about 1 in 300.
Right.
And they have high expense and decent complication rates. Like people get a lot of cramping with them. But I think once, and I am obviously biased as an investigator for it, but I have seen vastly less of the way of these side effects in tenapanor. So I would be much more excited about use of tenapanor as a laxative for general patients than I would be than linaclotide or lubiprostone, mostly just because of tolerability.
Yeah. And of course, the problem, particularly with linaclotide, is the development of colitis, which can be severe. So typically, these are not routinely used. segmental colonic resection, cecostomy, appendicostomy, all have been used. Okay, now what you're all waiting for, what is going to be the most common cause of pathological constipation, and that's Hirschsprung disease. It's more than 50 years since the discovery of the cause and treatment for this disorder. Its incidence is 1 in 5,000 live births. 80% of these patients are males. So this is an abnormality of the development of the enteric nervous system. The ENS consists of the myenteric or Auerbach plexus and submucosal Meissner plexus. Again, these are on the boards. And the neurons connect ganglia. They project to effector systems. This is the muscle. And the interstitial cells of Cajal. What do the interstitial cells of Cajal do? They elaborate something, which is frequently on the boards. What do the interstitial cells of Cajal produce? No attending can answer the question.
They're the like pacemaker cells, right? I mean, or are you thinking of something they secrete? Because I didn't know if they secrete anything.
Nitric oxide.
Thank you.
So the ENS is derived from vagal, truncal, and sacral neural crest cells. There's a ventral migration to the foregut that colonizes the developing gut in a rostral to caudal progression. Colonization is completed by 13 weeks with a full complement of the enteric nervous system neurotransmitters by 24 weeks. And new enteric nerve cells continue to differentiate through the first few years of life.
So, Bryce, you mentioned that they are the pacemaker cells. That's true. Do you think that the nitric oxide is related to that?
I mean, it could be. It's you know, transmitter molecules, so that makes sense. Maybe that's the neurotransmitter they use. I don't remember, so I'll have to look that up. I guess it's on the slide here as well.
So yeah, so it is the nitric oxide is one of the main regulatory aspects of their signaling, and so they are generally innervated by nitric oxide mediated signaling cells, neurons, and they kind of speak back to them that way. So that's one of that is the main neurotransmitter that controls at least the gastric movements. So that's why it is relevant here, and both those answers are correct. Sorry to interrupt.
So Hirschsprung is the absence of the enteric nervous system or elements of it for a variable distance from the internal anal sphincter. Smooth muscle relaxation is affected by non-adrenergic, non-cholinergic nerves mediated by nitric oxide. Aganglionosis leads to a lack of enteric inhibitory nerves containing nitric oxide synthase and nitric oxide, resulting in a lack of relaxation. So Hirschsprung's is a failure to relax. And it's a failure to relax largely because of the absence of nitric oxide. The genetics are complex. They involve mutations in greater than 7 distinct genes, which give rise to the same basic phenotype. Depending upon the condition, the state, it's either autosomal dominant or recessive. The autosomal dominant form is more associated with total aganglionosis and has a higher prevalence in girls. The penetrance of the mutation is low. The sex difference, again, we talked about in penetrance and expression. Penetrance depends on the extent of the aganglionosis in affected family members. There's a very high present penetrance when there's long segment disease. Again, autosomal dominant. Mutations are susceptibility factors, not determining factors. And identified mutations only account for about 50% of cases. In some cases, it's associated with inheritance on chromosome 10 in some patients. Learn this slide, it'll be on the boards. This is the RET proto-oncogene on the long arm of chromosome 10. Mutations in the RET proto-oncogene can be activating mutations or inactivating mutations. In the case of activating mutations, the disorder is multiple endocrine neoplasia types 2A and B. In the case of inactivating mutations, it's Hirschsprung disease. And it's autosomal dominant in total aganglionosis. This is also a disorder on the RET proto-oncogene, which is common in trisomy 21. Learn this slide, it'll be on the boards. Aganglionosis is restricted to the rectum and sigmoid colon in 75% of patients with Hirschsprung's. It only extends more proximally in 15 to 20%. It affects the entire colon and a variable length of the ileum in 8%. Rarely, ganglion cells are absent from most of the GI tract. That's a very rare phenomenon. I, for one, have never seen one. The
I saw
primary
one patient like that in fellowship who had, essentially bowel failure and then ended up also needing a liver transplant. She was a very sad patient.
Yeah, that's it's when that occurs, it is problematic to say the least. The primary defect in Hirschsprung's is an absence of intramural ganglion cells of the submucosal, otherwise known as Meissner's, and myenteric, otherwise known as Auerbach, plexuses. This results from a defective migration of ganglion cell precursors from the neural crest into the hindgut. This affects both cholinergic neurons and non-adrenergic, non-cholinergic neurons, which use, here we go again, nitric oxide as a chemical messenger. The absence of normal parasympathetic innervation prevents peristalsis, leading to constipation. This results in the proximal colon hypertrophying because of the attempt to overcome the functional obstruction caused by non-relaxation. And right where the tonic and the atonic bowel meet is called the transitional zone, and that exists between the normal and the abnormal aganglionic tissue. The pathognomonic feature of it is the failure of the internal sphincter to relax with rectal distension. Acetylcholine concentrations in the aganglionic segment are threefold lower than in the ganglionic segment. So here we have a typical case. Here's the visible transition zone. You can see here's the dilated proximal bowel. Here's your transition zone, and we have the narrow distal segment. Hirschsprung disease is only diagnosed in infants, right? Wrong. 15% in the first month of life, up to 50% in the first 3 months of life, 60% by the end of the first year, 85% by 4 years, 15% are diagnosed over 10 years of age. In those cases, the mean age is 26 years. And these patients usually have what we term ultra short segment disease, and they'll give you a typical history of dependence on enemas and suppositories, which mechanically dilate that very small distal aganglionic segment. When diagnosed in infancy, the symptoms are present within the first week of life, failure to pass meconium within 48 hours. I don't know about Dr. Levine and Dr. Wallach, but my antennas used to go up if there was a failure to pass meconium within 24 hours. And if it's not passed within 36 hours, that's a patient I want to evaluate. The book says 48 hours, but I think that's a little bit long. These patients may have a reluctance to feed. They may have bilious vomiting, although that's unusual, and they may have abdominal distension, although early on you may not see that either. So it's purely the failure to pass meconium within a reasonable amount of time, I say within 24 to 36 hours of life. These symptoms may be confused with obstruction from other causes, obviously. Suspect Hirschsprung's if, again, like I said, greater than 24 hours to pass meconium. Constipation onset is less than 3 months of age. Beware of a normal stooling pattern in breastfed infants. When I see a patient who's breastfed and the patient referred to me, oh, my baby's only having 1 bowel movement a week. Patient's 3 months old and is breastfed. Stool is passed, it's soft, no distension, no pain. That's normal. That's normal. I'm amazed that a lot of pediatricians don't know that. The passage of ribbon-like stools, the presence of abdominal distension or other signs of obstruction, and the young child with chronic refractory constipation, where no therapy seems to work. And the child who is constipated but has no stool withholding behavior or seems not to be bothered by it other than perhaps the presence of abdominal distension. And the child with constipation, where you do a rectal exam and find that there's a very narrow or empty vault. Clearly, the most worrisome problem associated with Hirschsprung's is Hirschsprung's enterocolitis. This is a child who presents with explosive liquid stools, fever, and severe prostration, indicative of enterocolitis. It's rare in the first month, but rises to 33% in the second and third months in patients who are not diagnosed. Complications can include perforation. We talked about enterocolitis, water intoxication because of use of enemas, failure to thrive, and anemia. These are all problems associated with undiagnosed Hirschsprung disease. Diagnosis, typically, depending on the age of the patient, depending on the clinical presentation, imaging studies may be very useful. They may indicate a transition zone. Again, this may be very difficult to show in an infant because the transition zone takes time to become obvious. And if one does a barium study, late films will generally show retention of barium at 24 to 48 hours. The most reliable diagnostic measure in infants is the rectal biopsy. We generally like to avoid the hypoganglionic region, which is present 2 to 2.5 centimeters from the anal verge. And the absence of ganglion cells on a suction rectal biopsy should lead one to recommend a surgical full thickness biopsy. So this is an infant who's had a barium study. And as you can see here, someone want to read this film for me and tell me what they see?
I can try and give it a go. So I see barium entering, like I can't see it in the stomach, but I can see it in the majority of the colon and towards the recto-sigmoid junction. Maybe that's what it is. I can see a narrowing, and then before that I can see a dilation.
Okay, so you've diagnosed this correctly, and so the key here, as Dr. Kahn mentioned, is that the distal segment or rectum is narrower than the proximal segment. Doesn't have to be all constricted. It's just narrower. And here's where your transition zone is somewhere here. You can see here, narrow, 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 narrow. All of a sudden, this appears to open up. This is what you'll typically find in an infant who has a barium study for Hirschsprung disease. The anal manometry, I used to do this all the time. I think we're doing it less and less, and maybe it's because of the patient population. But Under normal circumstances, a balloon is placed into the rectum and inflated to 50 mLs, and here you have the internal sphincter relaxation. In the patient with Hirschsprung disease, there's a paradoxical increase in internal sphincter pressure. This graph, or something like it, will be on the boards. So you should all know what the anal manometry looks like in a patient with Hirschsprung disease. This is the acetylcholinesterase stain, which shows an increase in darkly staining fibers within the lamina propria and muscularis propria, which in the absence of ganglion cells is diagnostic of Hirschsprung disease. So we have a hypertrophy of the nerves, but we don't have any ganglion cells to mediate them. And this is really the gold standard now in terms of staining. This is the calretininase stain. And when you do it, any brown that you see is a ganglion cell. So it's really very, very reliable and accurate, used in appropriate hands. So you see in panels A and panel F, no brown staining, whereas you see in B, C, D, and E, brown staining, which appears in various locations and is somewhat diverse, but again, indicates the presence of normal ganglion cells. The surgery, do you want me to stop, Tom, or should I continue? Do you want me to continue?
I'd continue. Yeah, just finish. And
So the surgery for Hirschsprung disease, there are two basic procedures which are done today. The Swenson, which is just an ilioanal pull-through, is not used anymore because there was a high likelihood of sexual dysfunction developing as a result of this procedure. The most common procedure is the Suave, where we have a mucosal stripping and we have the ganglionic bowel brought down in an aganglionic sleeve. So we have two walls here, the aganglionic and the ganglionic. The other procedure, I know that Dr. Velchek liked to do this, was the Duhamel. The Duhamel is you do a stripping and you have essentially a ganglionic and an aganglionic wall. This procedure I found to be more associated with postoperative defecation problems. I think most surgeons now will do the Duhamel. Will do the Suave. Complications are what you would expect in any surgical procedure. Keep in mind that enterocolitis is not only a problem in the pre-surgical condition, it's also a problem in the post-surgical condition as well.
The other thing that you can develop is
I think,
an
I
osteopatic
lost
stricture.
Schwartz's audio.
I'm sorry, Annie, someone else was talking.
Bryce was saying he thinks he lost your audio.
I can hear it now, though. Again, thank you.
It might have been that I was talking to. I was just saying that the other complication that you can see that takes a little more time to develop is an anastomotic stricture. And that one of the important things to remember about patients who've had a pull through for Hirschsprung's is that the internal anal sphincter is also still aganglionic. So you haven't fixed the problem, but you've improved it. So these kids do still need close monitoring.
So I'll show you later on a slide that's going to say, once a Hirschsprung's, always a Hirschsprung's. And that's good to remember. And it's good to remember, especially about enterocolitis. The patient presents with explosive liquid stools, severe prostration and fever. It's rare in the first month, but again, rises to 33% in the second and third months. It can occur both pre and post-operatively. I've seen patients who are months to several years post-operatively who develop enterocolitis. The pathogenesis clearly involves issues with an immature barrier defense and problems not only with the microbiome, but with our own innate and adaptive immune systems. So here's a little cartoon of the typical intestinal immune system. And in patients who develop enterocolitis, we presume that they have impaired GI mucosal immunity with immature barrier defense, develop dysbiosis, which I'll show you in a minute, and that leads to enterocolitis. So it's the dysbiosis which may be significantly involved in the development of enterocolitis, along with potential abnormalities in the overall innate and adaptive GI immune system. So if you look at the intestinal microbiota in Hirschsprung's disease, the ones that are the red arms are patients with Hirschsprung disease. The ones in the blue arms are control patients. And you can see there's a marked divergence in the prevalence of individual bacteria. It's not important to look at what specific bacteria they are, although enteric bacteria such as Shigella and Enterobacteriaceae are more common clearly in Hirschsprung's disease. So this is something to note, that there's significant difference between the Hirschsprungs and the control population. Furthermore, if we look at the intestinal microbiota and enterocolitis, the red bars are control, the yellow bars are Hirschsprung disease with no enterocolitis, and the blue bar is Hirschsprung's with enterocolitis. And as you can see, looking at these various bacteria, look at Shigella. This is enterocolitis. So there's an increase in certain bacteria and a decrease in other bacteria. So clearly, those patients who develop enterocolitis have a different microbiome. And this certainly is going to contribute to development of the clinical problem. In terms of enterocolitis, there are no controlled trials. What we typically do, and I know you've heard Dr. Wallach say this before, and I've said it before, in a patient was suspected, you want to get a soft red rubber catheter and use rectal decompression. Gentle irrigation may be tried, broad spectrum antibiotics, fluid resuscitation, and obviously a surgeon should be involved from the get-go. So to summarize, Hirschsprung's is the most common pathologic cause of constipation, and we all must be aware of its presenting signs and symptoms. As Dr. Levine mentioned, a high prevalence of long-term dysfunction, which can include obstructive symptoms, enterocolitis at any age, and incontinence. And finally, as I told you just a minute ago, once a Hirschsprung, always a Hirschsprung. Again, that was the same slide. Sorry to do that twice. So in summary, constipation is a common problem in pediatrics. Although most cases are functional, we must be aware of the warning signals of a more serious problem. Effective management is age-dependent and involves education, behavioral, and pharmacologic intervention. PEG 3350 is the safest and most effective agent for long-term management in children. In those patients who refuse to do it, as Dr. Levine mentioned, I have used lactulose successfully. You can look that up. There are defined regimens for the use of lactulose. Of course, you should know what lactulose is, because I'll ask you that one of these days. You better know. And then Hirschsprung's is the most common pathologic cause of constipation, and we all must be aware of its presenting signs and symptoms. So
you had patients that would take lactulose but not Miralax?
I have families who would give lactulose but not Miralax.
Huh. Just because, is it the New York Times article?
That's right.
Oh, yeah.
Okay.
This may still come up for you guys, fellows. There's a New York Times article in like 2014 or 15 that accurately noted the association of Miralax use and autism diagnosis. However, why did it accurately note that?
Because autistic kids get constipated often because of restrictive fiber deficient diets.
Yep, and because of underlying abnormalities in motility, as elucidated by our lovely colleague, Dr. Kara Margolis at NYU. So there is an underlying motility issue, there are sensory integration issues, and there are dietary constriction issues, all of which make it much more likely that you will be diagnosed with constipation if you're autistic. And we tend to diagnose constipation prior to autism. Thus, when you look at it like that, it makes it look as if the association could be causative for Miralax, which it is not. So people get very anxious about that. There have been some very nice long-term studies looking at Miralax safety. There's no associated risk with anything except for, in very rare cases, what's the negative problem you can generate with Miralax acutely, and what's the chronic one? Who is contraindicated from receiving Miralax?
So if you have an obstruction, so
Yes.
so if there's obstruction, you can potentially rupture.
Or what do you have happen before it ruptures?
Abdominal compartment syndrome potentially.
Yep, you can generate abdominal compartment syndrome. Every so
Right.
often, there is a case of this happening where it kills a kid. And this happens because somebody does essentially a very forceful clean out with especially NG tube clean outs where they don't back off when the kid complains of pain or other issues like that. You can get abdominal compartment with a partial or a complete obstruction. And even if you don't have the symptoms of obstruction, you can cause some issues. So that's the thing we really worry about. What's the other problem with taking Miralax if you use large doses of it chronically? What do we mix into PEG in the hospital for cleanouts?
Electrolytes.
Lightly.
Oh, yes. So what happens if you use a hyperosmotic solution in the inside of the intestinal lumen every day at large doses for long periods of time? Do you absorb things normally?
I guess not.
No, you don't. One of the things you can see in people with eating disorders who have Miralax abuse or laxative abuse is electrolyte abnormalities. You can, in fact, cause electrolyte issues with a lot of chronic use of Miralax. It is hard to do, but it is achievable if you are using Miralax to be skinny.
And you typically worry about patients with an underlying eating disorder, such as anorexia.
Yes,
Who
it is
will
using it
follow every meal with a Miralax chaser.
Yeah, using it for because you're also going to see it also basically lower the glycemic index, right? The same way where you essentially alter absorptive pathways by essentially just shifting the chemistry of it and the osmotic drives. So you really do want to think about that only in chronic use. I have never seen that happen to somebody using Miralax as prescribed, even at large doses for constipation. I will be very clear about that. I have had kids on like 3 caps of Miralax a day every day with celiac disease or something like that, and they are fine.
Okay. Here's a question. Somebody read it.
I can read it. So, a 16-year-old girl presents with complaints of constipation. She passes 2 to 3 small pellet-like stools per week and claims that she has not experienced a normal bowel movement in 2 months. She usually skips breakfast and buys lunch at school. Both her parents are employed, but the family tries to eat dinner together, usually 8 p.m. during the week. Physical exam demonstrates a well-developed, well-nourished adolescent who has no unusual findings. Rectal exam demonstrates normal anal sphincter tone and an empty rectal wall. Of the following, the most appropriate initial treatment of this patient's constipation includes A. Lactulose, B. Methylcellulose, C. Milk of magnesia, D. Mineral oil, and E. Polyethylene glycol. So I'm going to go with E. Polyethylene glycol.
Afraid not. Why is this patient constipated?
I'm just reading the question again.
It's her diet. It's her diet and her
It's
lifestyle.
a diet, yeah, right.
So
yeah.
where's the key ingredient there?
Oh, fiber.
Fiber.
Well, also,
The
what happens on
methylcellulose.
your rectal exam?
It's an empty rectal wall.
Does that usually happen if someone's like chronically racked up?
Only if they've just recently stooled.
Yep.
But
So
she
that
hasn't
does
stooled
suggest
in
that she's
3
just
days.
not creating a lot of rectal like stool volume.
Bulk. So then you could use like methylcellulose or lactulose.
Methylcellulose or psyllium. Yep.
Okay.
Now, obviously, we're all talking about medications here. The one thing you'd want to do is do lifestyle modifications in terms of diet, but this would be an adjunct. Next. Bryce, you want to do this one?
You are asked to see a 14-month-old boy who has rectal bleeding. The child's family recently moved into the area. He was seen at another practice 6 months ago because of a history of intermittent constipation, and a barium enema examination was performed. I assume this is the picture of it here, and it seems to show a change in caliber distally, which would make me concerned for Hirschsprung's, but I don't know if there's more to this question. Okay. For the past week, He has experienced several loose to watery and occasionally explosive bowel movements per day, which now contain streaks of blood. Over the past 24 hours, he has developed a low-grade fever, Physical examination demonstrates a well-developed thin child. His height is 77 centimeters. Weight is 9.2 kilograms? I forget how old he was. Temperature is 38.1 Celsius. Heart rate 110 beats per minute. And blood pressure is 90/60 millimeters mercury. His abdomen is moderately distended and diffusely tender with bowel sounds present. Initial laboratory data demonstrate hemoglobin of 10.4, white count 16, ESR 32. Of the following, the child's symptoms are most likely caused by A, C. diff, B, cow milk protein allergy, C. E. coli 0157H7, D. Hirschsprung disease, or E. inflammatory bowel disease. I'm guessing Hirschsprung's disease, although I don't know what particular bacterium is responsible. I suppose it could be A.
Well, I think you mentioned it. If we look at this, you can see, remember I said, and you mentioned the change in caliber. So the distal segment does not have to be, constricted. It's just relatively narrower than the most proximal segment. This is a patient with Hirschsprung's, and so this is a patient who's got
Hirschsprung's
enterocolitis.
enterocolitis. Yeah.
All right.
Thank you.
Board review on Wednesday.
Let me say one last thing before we sign off about constipation. Sorry.
I'm going to stop sharing my screen.
Okay. Parents, I tell parents one of the big things I harp on is like consistency, and behavior being just as important, if not more important, than the medications. And so in sufficiently concerned or motivated parents, I will also say, because they know their child best, and we're not child behavior specialists. So there's a couple of other resources that I sometimes offer, one of which is referral to a behavioral health specialist, like Dr. Steppen has seen some